I start recording. Alaaddin, it's time. We can start.
Okay. Good evening, good afternoon, or good morning, wherever you are in the world. Welcome to our online conference today. Before giving floor to our dear guest, I want to introduce our team. I will be the moderator of today's conference with Nana from Georgia. She is graduating resident at İvex Hospital. My name is Alaaddin Bayrak. I am one of the residents of the Neurosurgery Department of İzmir Training and Research Hospital. These online education meetings have started with Professor Hasan Kamil Sucu, the program manager of the Neurosurgery Department of İzmir Atatürk Training and Research Hospital, and goes on with the contributions of all the residents, also with the contributions of the neurosurgeons who graduated from the same department. I kindly ask you to keep your microphones turned off during the presentation of the lecturer to avoid voice and noise pollution. You can ask your questions not by opening your microphones, but by writing to the chat part of the Zoom program. At the end of the presentation, your questions will be asked to the lecturer and will be discussed. Mutual discussion is not appropriate for the format of our meetings. And now, I would like to introduce our guest. It's my privilege to present our lecturer, Professor Michael Lawton. Professor Lawton is President and Chief Executive Officer at the Barrow Neurological Institute and also Chairman of Department of Neurological Surgery, Chief of Vascular Skull-based Neurosurgery, Chairman and President of Barrow High School Education, graduated in 1986 from School of Engineering of Brown University, in 1990 from Johns Hopkins University School of Medicine. Between 1990 and 1991, he received training in general surgery alongside Dr. John Cameron at the same university. His residency in neurological surgery was completed in 1997 at the Barrow Neurological Institute. He received training in cerebral vascular and skull-based surgery alongside Professor Robert Spetzler. Between 2008 and 2011, he received training in endovascular surgery alongside Professor Van Halbach at the University of California. He holds academic studies at the Barrow Neurological Institute, University of Arizona, and University of San Francisco. Professor Lawton has an academic life full of achievements and awards, and he has been chosen the best doctor by many different communities. He is a member of associations such as AANS, CNS, and World Academy of Neurological Surgery. His personal series of aneurysm treated is over 4,700, and his personal series of AVMs resected is nearly 900. He has around 900 publications and published 7 textbooks, 108 book chapters. The most recent and outstanding are 7 aneurysm, 7 AVMs, and 7 bypasses. He has given numerous speeches nationally and internationally. Dr. Lawton contributes significantly to the training of numerous neurosurgeons with the scientific course and programs he conducts. This evening, Professor Michael Lawton will give a presentation on his experiments about cerebral revascularization. Welcome again, sir. Now you can start sharing your screen.
Okay, thank you for that introduction. Hopefully you can see my title slide. Is that correct?
Yeah.
Okay, great. Thank you for having me. It's a real privilege to be able to spend the evening with you in Turkey or wherever you happen to be. So I'm going to talk about bypass surgery, and the title of this talk is about evolving the craft, because I think it's a craft that is an evolution, and that's what makes it really exciting. This slide just sort of captures my case volume over my career since my residency ended. I've been at it for over 24 years now. The aneurysm number is well into the 5,000s, AVMs 960, bypasses 750. You can see for yourself, I've had a really fortunate career in that I've been able to focus on vascular neurosurgery primarily, and really dive into these really interesting lesions. This next slide, though, shows you a little bit of a sobering trend. The graph on the left shows that the line is climbing and things look great, but if you break it down by year, you see that year over year, aneurysm surgery peaked in around 2010, and since then there's been a steady decline in the volume of open aneurysm cases. And that's a reflection of how endovascular has impacted the practice of aneurysm surgery, not only in this country, but worldwide. So one of my reactions was to basically try and write the books that you mentioned, to kind of capture what I've learned so far and put it on the page so that the posterity will have some record of what I've learned and done, and hopefully preserve the craft that we and many before me have developed. The books that I've written are shown here, and the quote on the bottom is meant to send a message to those of you in the academic world. The pen is mightier than the scalpel. You know, we can do great surgery and do all these wonderful operations and put videos together, but unless you really record it and pull out your lessons and develop concepts and teachings, all that great work may go unnoticed or may go for naught. And you really have to spend time trying to gather all your thoughts and advance the field by synthesizing it. This book was really meant to preserve the art of aneurysm surgery, and I focused on the 7 most common aneurysms that account for 75% of the aneurysms that we treat. And my metaphor for the book was dance. If you could deconstruct an operation into a sequence of steps in much the same way that you choreograph a ballet, that you would then be able to transmit the craft and the whole process of doing these tough cases. And that was the idea. We did some wonderful artwork with my artist at the time, Ken Probst, showing these steps and numbering the different maneuvers, like these in the dissection of a middle cerebral artery aneurysm. And it really gets, I think, to the heart of what we do with each case, you know, gaining control of the aneurysm early, finding the different trunks that come out of the aneurysm, working in the safe areas to get behind and around the treacherous points where the aneurysm could re-rupture, and then finally getting a clip-on. And this was a lot of fun. But, you know, 7 aneurysms was really focused on the simple stuff. And when it comes to the giant aneurysms, what I was finding was that clip reconstruction often doesn't work so well. Here's a paper that we published years ago now, but I want to show you this case. This is a large or giant middle cerebral aneurysm. It's dolichoectatic, and you can see I did a picket fence reconstruction and got a good result. But here's the 5-year follow-up angiogram, and you can see that the aneurysm has regrown because there's dysplastic or pathologic tissue there between the 2 trunks. So for this one, I put in a bypass. This is a high flow bypass from the neck. And with that, I could swing a trunk over to the other side and create what I call a middle communicating artery, which is a communication between M2 trunks in much the same way that the ACOMs communicate between the A2 trunks. And it allows one bypass to then supply the entire middle cerebral circulation. So here's what that looks like. You can see the pathology. This is the view in the neck. And I'm going to get the proximal end of this radial artery graft plugged into the external carotid. You can see that aortic punch arteriotomy. You can see the end-to-side anastomosis. And now we're back in the Sylvian fissure. This is one of the trunks on the temporal side that comes out of the aneurysm. And this is just an end-to-side anastomosis. Now, when we do these, we usually just terminate the trunk with this clip here, and that dead end becomes useless. But if you think about it, that dead end can actually become a live end, and you can use that as a new donor. So here I'm clipping the outflow artery. I'm cutting that trunk off of the aneurysm, and I'm going to use that as my new donor. It swings over to the other trunk right here in the same space in the Sylvian fissure, and I'm going to reimplant that trunk onto the other M2 trunk as it comes out. That's a completed anastomosis there. You can see the two anastomoses here, and this creates our middle communicating artery. Now the bypass is supplying the entire middle cerebral circulation, and we can go in and we can distally occlude this aneurysm with this clip. You see the bypass, it supplies the one trunk swings over to the other trunk, and our middle communicating artery nicely supplies everything in the MCA territory. So the point of that case was that, when you're talking about giant aneurysms or complex aneurysms, they're different from the other aneurysms, the normal saccular ones. And they're a different entity. They require a different strategy, and that's where the whole bypass thing comes into play. So looking at my giant aneurysm experience, you can see for yourself here, the percentage that require bypass is nearly a half. And so I think when you get to these really tough bypass cases, you have to be thinking about bypass surgery and be prepared for that. So that leads to the third book in the series, the 7 Bypasses book. And so, the point of this book was to not only teach young neurosurgeons how to do bypass, but also to elevate the art. And part of what I wanted to do here was to develop a system of symbols so that we could have a way to design our bypasses, much the same way that we have blueprints for buildings and so forth. I wanted to develop a taxonomy for bypasses. And I also really wanted to push on these intracranial to intracranial techniques, because the ECIC techniques, I think everybody knows, Yasser popularized those over 50 years ago, and Sant and others popularized the high flow bypasses. But I think the ICIC techniques are generally under appreciated. And so that was one of my goals for the book. The metaphor for this book was architecture. And I'll just show you a few pictures here. This is the Golden Gate Bridge. I lived in San Francisco for 20 years, and I run in the mornings. This was from one of my morning runs, and you can see what a beautiful bridge this is. It's 1.7 miles across from end to end. These towers are 750 feet tall. The steel span across the water almost looks like it's floating in the air because those suspension cables are so thin. The cables really are, if you stack them end to end, it's 81,000 miles of cable going back and forth to make that suspension cable strong enough to suspend these 85,000 tons of steel that go across. So it's a real engineering marvel. And the point here is that, you could have created a very ugly but functional bridge here, but instead the architects here created a very beautiful and functional bridge instead. Some other examples, this is the Freedom Tower in New York, obviously where the World Trade Towers used to stand, but this now has become a national symbol for American resilience after the 9/11 attack. If you look in Spain, in Barcelona, this is this beautiful cathedral by Gaudí, and he was really passionate about a new form, a new shape, the parabola, and building the parabola into his architecture. He also use these branched columns, which were unique. They are evocative of trees. So it creates this beautiful nave of this of Basilica La Familia. Here's Utsan's Sydney Opera House, and you can see he used these shells, these concrete shells. He built them out on pylons into the water, so it creates the look of a boat going out to sea, setting for sail. And this is Frank Gehry's museum in Bilbao with these really beautiful forms and shapes with the titanium tile, creating yet another beautiful statement architecturally. And the point is that in neurosurgery, we can do the same thing. We can, what I call, turn plumbing into art. You know, we have an opportunity to not just do the routine and the functional, but also to focus on the form and create these really artistic expressions of our surgical craft. And you know, this is really what this talk is about. You know, even if you're not a bypass surgeon or haven't done a lot of bypass surgery, the point is that you bring to your work your personality and your passions, and you have to decide for yourself how that practice is going to look. Do you want it to be just doing the normal, average, standard stuff, or do you want to find a way to take it to that next level and be expressive and creative and really make a different kind of a statement? So this is the house that my wife Suzanne and I built in Arizona when we moved here. And what impressed me as we were building it, as I was writing the book, was just how you go from a vision in your mind about what you want your house to look like to having to build it. And that requires getting it on paper, building or creating a blueprint, working out all the specs, and then actually transmitting those details to a whole team of workers who build this thing from nothing. And here's the house later after it's been done. And the point is that in bypass surgery, we're doing similar stuff, but we had no blueprints. We have no system of capturing what we want to create. And so this was part of 7 bypasses, these symbols for the different anastomoses, which you can see here, the end to ends, the side to sides, the end to sides. We have symbols here for ways that aneurysms are included. We have different types of symbols here for the grafts that we use. Over on the right, you can see the 4 major territories, the vascular territories where we perform bypass, the MCA, the ACA, the basilar apex, and the pica territory. And these are like a little wiring diagram or a place to start in your design of your bypass. And with these symbols, you can actually create these schematics. So if you have, this is our Barrow bypass coder, and you can go online to our website and you can play with this. If you have an idea, you can click on an anastomosis and a graft, and you can drag these things in and out, and you can construct your bypass. You can go from having a wild idea to an actual game plan. And this kind of makes that process a little easier. So this is how the blueprint gets put into action. And you can see that as the schematic is being built, we're also getting up here this code, which I'm going to talk about next. I think you get the idea there. So the coding for bypass is really dependent upon first finishing out the alphanumerics of the nomenclature for brain arteries. This was the one and only paper I wrote with Al Roten. You can see at the end of this effort, we now have alphanumerics for every piece of artery, every segment of artery in the head. And so you have an address essentially, and you have a way to identify the part of the artery or the arterial system that you're talking about. And with that, you can then create code in much the same way that computer scientists create code for the programs that they run. And the bypass code is completely specific. It's so much better than our current system where we say that we do an STA-MCA bypass, but we don't know whether that MCA recipient site is on the cortex at the M4 segment, or down in the sylvian fissure at the M2 segment, or what kind of anastomosis we're using. In contrast, the bypass code tells you everything. You've got the side, you've got the segment, you've got the arteriotomy, the recipient, donor and recipient arteriotomies. This little superscript will tell you whether to do it with an interrupted or a continuous suture technique, whether you use intraluminal suturing. And you can then construct these codes. So here's an example. This is a very complicated bypass. It's what I would call a double reimplantation bypass. You can see the schematic for it. It starts at the A1 here, runs over to the sylvian fissure, and plugs into the M2s, both of them, first with a side to side and then with an end to side, so that you can trap this bifurcation. Well, you can draw this out with that bypass coder that I just showed you, or you can write it out as a code. And this code tells you absolutely everything that this schematic tells you. It tells you the donor, it tells you how the arteries are put together, it tells you the graft that you're using, the suture technique, the anastomosis here to the M2. And you can go from this pathology to this solution without any kind of error or confusion. And so that's the beauty of this code. And we published this, and we're hopeful that people will use it, embrace it, and elevate the description of the bypasses that everybody's doing out there. So here's the taxonomy for the bypasses. Of course, it's 7. That's my thing. And you can see in this table the different categories of bypass. The first category is the standard ECIC bypass. That's the STA-MCA bypass, the Osler-Gills bypass, first generation. The second category is the high flow grafts that go down to the neck using an interposition graft, either to the external or common or internal. This next group, 3, 4, 5, and 6 here, these are the intracranial to intracranial bypasses. These are reimplantations, in situ bypasses, reanastomoses, and the short intracranial jump grafts, or ICIC interpositional bypasses. So these are the ICICs that I was talking about that I wanted to really try and push. And so those form the 3rd through 6th category. Finally, number 7 is the combination bypass. That's when one bypass isn't enough. You need multiple, and that's not an infrequent occurrence. That was second only to the ECIC first generation here. And this could be, one ECIC and one ICIC. It could be 2 ECICs. It's whatever is involved in the reconstruction, but it's more than one. There are the classifications of aneurysms, because it's important to, again, refine our terminologies. When we talk about MCA aneurysms, we should really be talking about whether they're pre-bifurcation, bifurcation, and post-bifurcation, whether they're sylvian, insular, or opercular. And this classification is helpful. And when you have that kind of specificity in your terminologies, then you can really create these tables where you have all of your bypass options, all 7 here. You have all of the different variety of aneurysms that you could encounter. And then you can map it all out so that when you get one of these, you can sort of walk down your menu of options and make your selections. And I think it's a nice way to make sure that you haven't forgotten to consider a bypass that's on the table. There are also algorithms. So there's certain key questions that will help you or steer you to one bypass over another. So for example, if you've got a complex MCA and it's on the bifurcation and it's ruptured, then you're going to want to trap that one, and you need to do a combination bypass. If it's not ruptured, then you might be able to just do a proximal occlusion and do a different kind of a bypass. So these are the algorithmic ways of answering the questions or arriving at your selection if that's your preference. So I'll show you another case. This is the case that I mentioned earlier, and this is that double reimplantation. You can see the sylvian fissure split here. We come down behind this giant aneurysm. You can see the frontal division coming out of the back of the aneurysm right here. A little bit of atherosclerosis there. On the other side, we're going to find the temporal trunk, which is right there. So these are the 2 trunks coming out. And the idea for this is to trap this aneurysm and bypass both trunks using the A1 as our intracranial donor. So this is the A1, and this is the ICIC mentality. It's using stuff that's already in your field rather than going down to the neck and making another incision and another potential problem with the tunnel, for example. So this is our arteriotomy in the A1, and I'll just take the liberty of advancing this through, but this is our end-to-side anastomosis to the A1 segment. You'll see lots of sewing. I got lots of videos in this talk, so I might just kind of jump around through parts of this. But this is the first step. You want to get the graft arterialized so that it's live. And here the anastomosis is completed. Now we're going to run the graft up. This is a saphenous vein graft. This is the frontal division. We're going to do a side-to-side anastomosis here. And this is a variation of the reimplantation technique. We're essentially reimplanting that frontal trunk onto the mid portion of the interposition graft. And you can see it's going to be a side-to-side. And for these, it's an intraluminal suture line. So this first stitch brings the vessels together. Let me jump ahead a little bit. And you can see that the inner wall of the graft comes together with the inside wall of the MCA. And we're creating this side-to-side connection here on the first of the two trunks. More sewing. Here now, we're coming down on the outer suture line. This is the second suture line of this anastomosis. And you can see how these really nicely come together and provide flow immediately to that trunk. So I can essentially trap that trunk, I can feed it from the graft, and I can swing the other end of the graft here around to the temporal side and work on the other trunk. So we'll do that next. This is the end of the graft. This is the temporal trunk, so the other one coming out of the aneurysm. And you'll notice that I'm doing, again, an intraluminal suture technique. So it's like an in situ bypass because I'm sewing inside the lumen of both of these vessels here. And that's going to be an important concept later on in the talk when we talk about fourth generation bypass. But let me jump to the end here. So we get through this anastomosis, everything comes together. We can put our clips now on the aneurysm to trap it. So these are permanent trapping clips. Now you see the three clips. You can see the aneurysm is quiet. The bypass is flowing nicely. So we've achieved our trapping. And when we open up the aneurysm, you can see it's completely dead. Suction decompresses very nicely. So that's the example of an intracranial to intracranial combination bypass. You saw there were two bypasses needed, one to each of the two M2 trunks, and it was all intracranial, not at all extracranial. So this is an example of a third generation ICIC bypass. And there's our angiogram. So I want to just spend the second half of the talk just talking about evolution. And these are the different examples of evolution that I'll cover. So the first point is ICA bypass. So when I wrote the book, I really didn't even talk about ICA bypass because they were so infrequent. It really wasn't worth dwelling on. But I thought to myself, if the framework that I'm proposing has value, I should be able to do it in a new territory like ICA. And so here are the 7 different types of ICA bypasses, 1 through 7, and you can see pictures of all of them. These are all bypasses that I've done. I'll show you examples of that. Here's one example. It's a ICA thrombotic aneurysm. The lady had mass effect on her pons. So the approach here is going to be a ICA to pica. So this is an example of the in situ bypass. And here we're in the CP angle. Here's the 7th and 8th nerve. The 5th nerve is up here. The aneurysm is between this infratrigeminal triangle here. This is the vertebral artery with hypoglossal draped over it. That's a very small branch, but pica was a little bit higher up. You can see pica here, Ica there, and I was able to bring them together. So this is going to be an Ica pica side to side in situ bypass. And the thought being is that if we can revascularize Ica using pica, we can then go and we can trap our aneurysm, we can perform a thrombectomy, and we can not only protect her from rupture, but also decompress the mass effect on her brainstem. So here's the suture technique. You can see our anchoring stitch going in, bringing the vessels together. Second stitch here. This will just be a side-to-side technique. This is that intraluminal suture line here that you're seeing at the end. Here's a nice view showing the stitch work. We can now oversew the second suture line, come off with our clips, and now we have an Ica to pica communication. There it is, right down here in the lower part of the CP angle. You can see the aneurysm now up here. So now we turn our attention there. This is Ica coming out of the aneurysm. That's the sixth nerve, abducens nerve, coming over Ica. And we're going to first place a distal trapping clip on the back end of the aneurysm. We now go proximal. So I'm working my way towards the basilar trunk. If you look in this little space here, you'll see just enough room on the front side of the aneurysm in here to place our clip. Keep your eye right there. There it is. There's our inflow to the aneurysm. We place our proximal clip right there on that spot. Aneurysm is trapped. We can now open up the aneurysm, do a thrombectomy. Here's our thrombectomy. You can see that dead sac thrombus on the inside. So now her pons is decompressed. And now I'm going to show you the indocyanin green. Here's our bypass down here. You'll see dye that goes retrograde up Ica all the way up to our aneurysm clip here, which is trapping the giant aneurysm. All right, so here's a distal Ike aneurysm. I think I'll skip this in the interest of time. This just shows you the depths at which you can do an end-to-end reanastomosis. This is turned out to be a mycotic aneurysm. This is sewing the ends of the Ica together after the aneurysm is excised. The sixth nerve is right underneath our anastomosis, just to give you a sense of how deep this is. But you can perform this because the artery has some redundancy and we have decent exposure here. Here's the indocyanin green, which shows filling in our Ica as it's been reperfused there. And postoperatively, you can see this is her Ica, beautifully reconstructed, no evidence of aneurysm. And despite her very significant subarachnoid hemorrhage, she made a perfect recovery. And I saw her recently. So that's the Ica. I'll turn now to the anterior cerebral artery. The ACA territory is actually a beautiful territory for bypass because you've got so many vessels in the neighborhood. This was a paper that I wrote with Dr. Abla. We published 10 cases back in 2015, and you can see for yourself the different types of bypass as well. In the subsequent, that was a 16-year period, and in the subsequent 4 years, we went from 10 of these to 23 of these. And it just goes to show you how if you adopt this approach and you really are trying to turn plumbing into art, you can put these together in so many different ways. For the in situ bypass, you can do an A3 to colosomarginal as shown here. You can do colosomarginals together. You can do pericallosals together. You can do A3s together. Or you could do double bypasses that bring together both the colosomarginals and the pericallosals. So here's an example. This is a colosomarginal to colosomarginal working down the fissure. The arteries are together here. This is the anastomosis after it's completed. Another example here, an A3 to colosomarginal. You can deal with a caliber mismatch with your linear arteriotomies. It's no problem. So these are really ripe for innovation. Reimplantation is the same story. You have parallel vessels side by side. So you can take arteries from the left and move them to the right or vice versa. You can also take arteries from the callosal marginal and swing them down to the pericallosal or bridge the cingulate sulcus or gyrus. These are examples of that, reimplanting from one side off of this aneurysm over to the other side. And you can do these A1 donor bypasses like I showed you earlier in that earlier video. This is the A1 donor site. It's a beautiful donor vessel. This is another example of one of these bifurcation aneurysms sewn with the A1 to M2 bypass. I'll show you this one. This is interesting because it's a little different. It's a giant ACOM. When you look at the aneurysm, it's mainly thrombus filled. But if here's the angiogram, the filling component is actually quite small. Here's the subtraction angiogram and 3D reconstructed angiogram. There's the 3D. You can see spin. That the for this one, we're going to rebuild this anatomy by doing an M2 to A2 bypass. We're going to also reconstruct the ACOM by doing an A3 bypass distally. And then we'll let the flow be dictated by the demand in these vessels. So you're basically deconstructing, then reconstructing normal anatomy into bypass anatomy. And this is what the schematic looks like. You can see for yourself the code. It's an M2 radial artery to A2 bypass with an A3 inner, inside 2 bypass to bridge across. So here's what it looks like. This is performing the squeeze plate craniotomies. The dural flap. This is the exposure, and you can see the flap here bringing us down to the interhemispheric fissure for our A3 bypass. The craniotomy is both a terional and a bifrontal. And here we're right on top of the corpus callosum. You can see the A3s parallel to one another. And this is what the A3 bypass setup looks like. Here's the stitch work. You can see the intraluminal suturing first. Then we run the other suture line. We come off with the clips. And this is essentially our new ACOM. We've shifted the ACOM back, and it's now residing distal to the aneurysm. Now with that in place, we go down to the ACOM. This is the ACOM. The A1 is over here. This is Huebner in between, and this is A2 coming out of the aneurysm. The aneurysm is right up at the top of your screen. And there's really no way to clip this aneurysm. It's too big, it's thrombotic, and we've got perforators on the backside. So our bypass will go into the A2. This A2 segment here is a beautiful recipient, nice thick arterial wall. And we're going to use a radial artery graft here, which comes down. I'll just zip through this. This is midway through the bypass. Now we're doing the next suture line. And now once that's in place, we run the other end of the graft up to the sylvian fissure. This is going to be our MCA donor site right here. And so we've got to plug in the more superficial end of the graft. And again, you'll notice I'm doing an in situ technique, which means I'm inside the lumen, sewing the inside of these vessel walls, making this a 4th generation bypass. And you can see as we round the horn here, we just keep going with our suture, and we close over the second suture line. So this is now at the end, tightening down our loops of suture, tying them down. And now we've completed the construct. We've got M2 supplying A2. A2 courses up to the A3 bypass, flow shunts across, goes around to the other side, and actually gets all the way down to the base of the aneurysm where the perforators are coming from. Now we can go down to the aneurysm and trap this thing. So this is now the A1 inflow. We're going to close that. Notice Huebner right in between the A1 and the A2. We're going to close the A2 that comes out of the aneurysm because we don't want our bypass to be dumping into the aneurysm. So this next clip closes the A2. And you'll notice Huebner in between. Huebner is preserved. And our bypass is actually going to fill Huebner. It's going to go all the way around from M2, around and all the way to the other side, down and around. And you're going to see Huebner right here filling in between, right there. You see that pulsation of flow? That's bypass flow that's gotten all the way around the horn from the other side. He had no A1 on the contralateral side. It was all a dominant A1 on the surgical side. And so we needed to completely reconstruct this. And this is what the final angiogram looks like. You see our graft here in purple. It goes to the A2. Our A3 bypass is here, the blue arrow. You can see the flow comes through the bypass on top, runs around, and goes all the way down and across to the recurrent artery at the bottom. So these are all just examples of the things you can do in the interhemispheric fissure. These are cases from the first paper that I mentioned, cases from the second paper that I mentioned, and the point is that a lot of evolution has happened in the meantime, and a lot of new variations of this bypass territory. So let me talk about fourth generation. I've shown you double reimplantation. The first time I did this, this was an example of really a second generation bypass using the neck as a donor and doing 2 reimplants up in the sylvian fissure. But in that case, you can ask yourself, was that side-to-side reimplantation, was that really a reimplantation, or was that an in situ bypass? It's a little bit confusing because we did an in situ type technique and we brought those together like we would the A3 bypass. And in that next bypass on the temporal side, we did an in situ end-to-end. Is that really an end-to-side reimplantation, or is that an in situ technique? So you can see that the concepts get a little fuzzy here. And so I have come to view these as a completely separate entity, which I call the fourth generation bypass. And the type A is really when you use a normal construct like an end-to-side, but you use the in situ technique or an unconventional technique to do your sewing. The type 4B is using a completely unconventional construct, meaning, if you're going to do a reimplantation, instead of end to side, you're doing a side to side, or you're doing a different kind of anastomosis. So this is what's meant by fourth generation. And when you apply that concept to our categorization of the 7 bypasses, what you see here is that within each category, we have these new options or these new twists that allow us to bring things together in different ways. So all of these 4A and 4B bypasses are new. Same with these reanastomosis bypasses and so forth. So let me show you some examples. We'll start, actually, I'll skip reanastomosis and show you this one, the reimplantation. So for reimplantation, a type 3 reimplantation would be essentially, bringing in an STA and then reimplanting an M2 over to there with an end-to-side anastomosis. If you do the suture technique intraluminally, it becomes a type 4A, or if you use a different type of anastomosis, like here, a side-to-side or an end-to-end, then it becomes a type 4B bypass. So I'm going to show you this case. This is an example of a fourth generation bypass. We'll do a double barrel bypass using the STA. The aneurysm itself is at the bifurcation. It's very dolichoectatic. You can see the clips going on here. And just a routine double barrel. But now this is where it gets interesting. We're going to then trap our aneurysm, and we're going to bring the stumps of the trunks together end to end. So this is an end-to-end reimplantation, and that creates our middle communicating artery right there. So that middle communication allows the bypasses to perfuse the trunks according to the demand. These I'll skip. These are just STA, MCA bypasses, nothing fancy there. Those go in, we trap our aneurysm here, and now this is the part where we cut the trunks off of the aneurysm. So here's one trunk over here, the other trunk is here, and we're going to do an end-to-end reimplantation. So reimplantations are typically end-to-side. This is end-to-end, and you can also see that I'm sewing intraluminally. So it's both a 4A and a 4B. But by bringing the trunks together, the M2s communicate with one another, and you can see now how the STAs can perfuse the communication, and the communication will decide based on demand how the flow distributes itself. So there's the middle communicating artery, there's the STA, there's the other STA, and this is our construct here. Over on this image to the right, you can see how that candelabra of the MCA is completely perfused by our MCOM. Here's another example. This is, well, actually I showed you that one. This is the other example. This is another MCOM, another dolichoectatic bifurcation aneurysm, which you can see here. The trunk here comes out the bottom. The trunk over here also comes out the bottom. So here's our graphic. What we're going to do for this, we're going to use the A1 as our donor. We're going to plug the A1 graft into the M2, one of the M2s, and then we're going to do an end-to-end reimplantation, like that last case. So there's our middle communicating artery. It's an end-to-end. Here's the pathology at surgery. Our first step is to do our A1 bypass, which is shown here. This is now the distal end of the graft going to the M2. So there we've completed that. And now, once the bypass is in, we can then cut the ends off of the aneurysm and bring them together. And I'll just take you to the end of this, where these two ends here are coming together. In this case, under a little bit too much tension for my taste, but we got them together. And you can see here at the end, here's our end-to-end reimplantation. The two trunks are together. Our graft is feeding one of the trunks, and the flow redistributes itself around the MCOM, and you can see filling of both trunks distally. So another example, these are just 3 different variations of the MCOM, and shows you how you can be creative as you go. So these are what I showed you, different variations of middle communicating artery. You can see our blueprints here, our schematics. You can also see our code as we construct our code. We come to the bottom here with our final code for the case. And it's a really nice way to describe this. So I've shown you these different ways that we evolve bypass surgery. And this is a slide that just shows you that there really are endless ways to bring vessels together. It just requires imagination. It requires a little bit of daring. And it also requires that you go down to the lab and experiment a little bit, see if these arteries come together in ways that are physically possible, but also in ways that you can comfortably sew. I'll just show you one last case, and then we'll open it up for some questions. But this is a case of some unusual anatomy. You've got a dual origin pica. You've got an aneurysm that's distal to the confluence of these. And we're going to use one of the branches to free up from the vertebral artery, swing it over distal to the pica, and that becomes our internal bypass here. So here's, this is an animation showing this case. There's the example. Our aneurysm is here. We've got dual origin picas. We're going to use the proximal limb of this pica. We're going to cut it free from the V4 segment. We're going to swing it over to the distal pica, and we're going to do an end-to-side anastomosis, which will trap the aneurysm. So that's the idea. It's a gift from nature, so that we don't have to harvest an occipital artery or do anything else on the other side. This is that confluence of the picas coming together. You can see the aneurysm down in this space over here. And I tried to clip this. You'll see that the clip goes on, but the tissues are terrible. They don't hold the clip. The aneurysm ruptures during the clip application, so I have to escalate to my bypass. The aneurysm is really just this hole in the artery wall. And so here now is the proximal limb, which I'm cutting free. That's now going to swing over to the distal pica, and I'm just going to sew that in. Just a simple end-to-side anastomosis. that is now our internal jump graft, making this an IC bypass. And just a running continuous suture line. Here, putting in our final knot. And our icy green shows everything looks great. And this guy did well. All right, so I'm gonna jump ahead now to my concluding slides. I showed you this slide at the beginning. This is the depressing trend line for aneurysm volume over the years. But if you look at the bypass volume, you can see that the bypass curve is climbing steady. So I think there's hope for those who have an interest in bypass surgery. It provides you with those answers for the tough cases, and the lines are going in the right direction. It's a wonderful operation. It's very simple. It's very beautiful. It relies on dexterity and craftsmanship. It relies on innovation without technology or anything fancy. It's just brain power and going in there and doing what you imagined you could do with the arteries. And I think for me, that's what I think is new in vascular neurosurgery. And so I'll end with this slide. You know, it's really about bringing together your head, your heart, and your hands. You've got to be creative and strategic. You've got to have good dexterity and develop those skills. And finally, you know, you got to pour your heart into it because, as I said at the very beginning, if you just do the standard stuff and do your simple bypasses, you won't evolve, you won't advance the craft. But if you pour your heart into it and you are creative and you know, are always looking to make an advance, then I think that's where it gets interesting. So with that, I will stop.
Thank you very much, sir, for your excellent presentation. There are many questions. Before the starting discussion part, I would like to ask you one question about hyperperfusion syndrome. Hyperperfusion syndrome can be seen after bypass surgery. What is the incidence or risks of hyperperfusion syndrome in bypass surgery?
Yeah, well, it happens occasionally. I think it's very rare. I think it's mainly seen in cases of moya where the brain is depleted of flow, and then you do a good bypass and you hit it hard with too much flow. But it's very rare. I mean, I've done, as you saw, 750 bypasses. I can only remember a handful of cases over my career. I think it's an overstated, overblown concern. I think certainly with the aneurysm cases that I've been talking about primarily, you don't see that.
Okay, thank you. I want to go on one question from Dr. Efecan Erişken. Sir, thank you for inspirational lecture. How is your postoperative management in these revascularization surgeries? Which complication do you have mostly in your series?
Well, the postoperative management is pretty straightforward. I put them on aspirin. I do an angiogram to make sure it's patent. And that's really about it. I think, you know, the most troubling complication is when the bypass doesn't take and you have an occlusion. It's frustrating for the surgeon and the patient. It's a little embarrassing. You have to either redo it or find an alternative. But you know, we published on my bypass patency rate. It's in the very high 90% range. For the simple bypasses, it's near perfect. It's as good as you can get without the usual strange oddball cases. But for the more complicated cases, it's challenging. Sometimes, you know, with the constructs that I've been showing you, the bypass patency rate might not be in that high 90% range, but it's in the 90s. And it just depends on technique and meticulous execution.
Thank you, sir. Before pass the other questions, I would like to give floor to Nana.
Yeah, thank you. Just, can you please confirm that you can hear my voice?
Yeah, I can hear.
Yeah, okay, great. Once again, many thanks for your wonderful lecture, and I'm here to ask you a few questions from the audience. So Dr. Gupta from India has a question. How do you overcome the disadvantages, the ischemia time, and the decreased long-term patency in IC bypass? As you have mentioned in your text, and how to overcome it, can we, and another question from the same person is, can we apply for an observership and fellowship at Barrows for vascular and endoscopic trainings? That's two questions from the same person.
Yeah, yeah. The second question is observerships are doable here, and we welcome visitors from around the world to come to the BNI and see what we do and how we do it. People just need to send me an email with their CV if they're interested, and we'll take it from there. With regards to reducing ischemia time, well, you know, it's really all about speed. You have to develop your technique to the point where you can do a good job, but do it quickly. You know, the only way to get to that high speed level is to just practice. So I think it's a matter of going to the lab and eliminating the inefficiency in your technique, feeling really comfortable with the instruments and the handling of the tissues. You know, I think as you practice, you get good. I usually like to tell people that they should sew at a pace of about a stitch per minute. And if they can do that, then that's plenty fast. The site selection for your bypasses is really what determines the ischemia tolerance. You don't want to occlude segments of arteries that have perforators that won't tolerate temporary occlusion times. You want to choose segments of arteries that are a little bit more distal, the M2s instead of the M1s, or the P2s instead of the P1s. And when you do that, then you shouldn't have a problem with ischemia time.
Thank you. And I'd also like to add one note that my direct supervisor in neurosurgical residency, Dr. Jakob Zertwadze, was also trained by you in this observership, which was just mentioned in this question. He's attending here. So, okay, the next question is from Dr. Aydin, and he's asking, so thank you and congratulations for your real exceptional expertise presentation. How is your present indication changed after the evolution of endovascular techniques such as flow diverters and availability to access to distal lesions by macrocatheters with stents?
Yeah, it's a good question. You saw the curve. The curve is turning downward. So I think that flow diverters, coiling, advanced devices like the web, these have all eaten into the amount of not only aneurysms but bypasses that I do. A great example is the cavernous sinus bypass. You know, we used to treat cavernous aneurysms with high flow EC-IC bypass. I used to do probably a dozen of those a year, and now those are completely gone with the flow diverter. So there has definitely been a high impact from flow diversion on bypass surgery. The numbers are down, but as I've shown you, most of the videos in this talk are contemporary cases. They're not always amenable to flow diversion or endovascular therapy. So you really have to work as a team and evaluate options on both sides and make your selections as appropriate.
Okay, thank you. So the next question is, thank you for your presentation. And do you evaluate the bypass designed by preoperative digital flow simulators? It is asked by Dr. Emre Saliskan. Sorry, not pronouncing properly.
Well, we've tried a lot to use flow simulators preoperatively to help us predict what bypasses to do and how the aneurysm will respond. Unfortunately, computational fluid dynamics is not so great at predicting that. And I found it to be a little bit disappointing. Not that we're not trying, because I think there's great potential there, but I think it's not been as predictive and reliable as I would like it to be. And so I think we're continuing to work with it and see where we can get with it. So it's 10 o'clock here in Phoenix, and I have to go because it's a work day for me and I'm operating. So I want to thank you all for having me and for listening to me, and it's been a lot of fun. I hope it was helpful for all of you.
Thank you so much.
Okay.
Thank you.
Okay, so I have to stop the questions here. Okay. Thank you once again for your wonderful lectures.
Thank you.
Thank you so much.
Thank you.
Bye-bye.